It now gives me great pleasure to invite my good friend from many years, Ranjana Mathur, who is a who had her education in Mumbai and has now been in Singapore for many years and as a senior medical retina consultant in Singapore. And she's going to give the keynote address on uncommon maculopathies, the role of multimodal imaging in diagnosis.
What might be something that we may see in clinics in macula as uncommon pathologies. So why, if they are uncommon, should we even bother to look at them? The reason being that you might see some of them in subacute and chronic phases, and if you suspect them, it actually reassures the patients to know what is the cause for their poor vision. So consider these diagnoses whenever you have any of these, and particularly when their symptoms are very vague but the vision that the patient has is very poor. What are some of these indications, diagnoses? It may be UM or arpatholitis or some of the viral pathologies, and we'll take them one by one. So UM is actually very common, but not so well known. And if you look at the presentations, there are young patients who come with poor vision and morbidity that causes them to be very distressed because they can't see. And what you see at the RPE level is these exudative maculopathies, which actually resolve even without any treatment. So let's look at the natural course. They are rapid, they completely resolve, with most patients getting their vision back completely. But there may be residual hyperpigmentation at the level of RPE with some choroidal perfusion deficits, and there can be recurrences. CNVs usually can occur, but they are very, very seldom. What may be the causes? In Singapore, we have huge outbreaks of hand foot mouth diseases, so we see them in them. I've also had a patient that we've published in Zika and some of these other viral conditions. Recently, somebody has also published it in COVID. This is a patient, she's a young 34-year-old. She had a child who developed, she was in KG and developed hand foot mouth disease. She was asymptomatic, but the mother came with this hypopigmented large lesion with poor vision of 636 in the right eye and counting fingers in the left eye. Now look at that RPE. Basically, it shows you that there is this boggy, swollen RPE complex with IZ that is involved, and that disrupts the photoreceptors. And this is very well picked up on the OCT, but if you look at the FFA, it doesn't give you, and the IR, it doesn't give you the clinical picture that you see on the OCT, which basically just shows initial hyperpigmentation at the RPE with some blockage and then late mild staining. What about the left eye? She had also left eye, which was more severely involved, although clinically it did not look so bad. We observed the patient, and within 3 months, the patient went to here and with a vision of 612 from here. And same thing in the left eye. She developed RPE granularity, but the exudative changes and the bogginess that you could see initially at the OCT had resolved. When last reviewed a couple of months ago, she's actually developed six. Her vision is recovered to 6/6 with no central scotoma, but she does have persistent RPE changes, and this is what you might see the patient in with these kind of IR changes, and you may wonder what this patient had. And one of the diagnoses that differentials that you have to keep in mind is UM. Yet another patient, she is, so this is a patient who tested positive, like I said, and resolved completely. And some other viral conditions that have described these are some of the ones that you may want to read through. What about this lady? Now, this patient also has very good vision, but persistently complains of seeing photopsias and visual loss in the temporal fields. Now, if you look at her, you really can't tell very much on the color picture, and OCT at a cursory glance will not tell you anything unless you critique it a little bit. This is her fundus photograph, and this is her left eye with a similar kind of picture in the left eye. So, what is it that actually is wrong with this patient? So, when this patient came to me after almost 2.5 months of her symptoms, when she was persistent, and only abnormality that I could see was this granularity in the temporal field with mild ERG changes, with nothing much, some scattered defects on the visual fields. But I was suspicious because I had seen a case like this earlier, and I persisted and I asked her a relevant question, and that was, did you have any fleeting rashes? And she confirmed that yes, she has these kind of rashes on her feet and on her trunk, which come and go, and she tested positive for syphilis. So although it did not give me any information on FFA and her color finger photograph as well as HVF, but her OCT, that mild granularity, is what clinched the diagnosis. This another patient who came 2 days of history. Again, if you look at it, his symptoms are similar to the first patient that I showed you, but his fundus photo and her autofluorescence is completely different. And FFA does not show much changes, but in the later frames you can see some hyper autofluorescence, and ICG shows dense hypo autofluorescence. This patient lived in an area where we were having pandemic at that time of Zika, and he tested positive for Zika. And just like the first patient with UM, he also recovered within the first few weeks of developing the symptoms with complete recovery. He tested negative for all other blood tests that we standard do for UMs. Then comes this second subtype of macular conditions that you see in patients. Again, young patients, usually unilateral, but they have again catastrophic central scotomas in some patients and metamorphosis in most of the patients. So, what is a clinical sign that you have to look for is with this dark macular lesion, which is surrounded by yellowish hypopigmented lesions. It may look like a very subtle sign on fundus photograph, but OCT will pick it up. So you've seen a lot of these images today, and you can see that this patient is actually a nomenclature failure, because it's not RPE that is the primary source of the problem, but the ellipsoid zone. Because the ellipsoid zone outer segments are not phagocytized, they start to develop and swell up their photoreceptors, which then causes the symptoms. But the RPE, which is in the red line, actually always remains undamaged. So looking at the patient, you will see that they will ultimately have some stippling at the RP level with some yellowish halos, and otherwise very unremarkable FFA and ICG. So this is our patient. She had this RPE kind of thing, hyperreflective lesion. You can see some defect in that IZ zone and EZ that is getting disrupted with some elevation of the ELM, but the vision was not very much affected, 6/9. She was just having metamorphopsia. We look at the vasculature was not affected at all at any of the segments. And I'll show you the left eye, which then 6 weeks later, she had the right eye symptoms that disappeared, but the left eye developed 3 years later. Recently, she's come up with again similar kind of arpitelitis. And if you look at the segments or the cubes of deeper layer, you can see some dark lesions, which may suggest that there may be choricapillary deficit, but FFA does not show any abnormality. Another patient who may end up looking like same patient who may end up on ICG look like showing fine signs of mutes, but actually again has partly healed arpitelitis, which and her visual fields were negative. So you do need to keep that index of suspicion, because as this arpitelitis heals, it causes EZ to enlarge, but the hyperreflective lesions to resolve, and they may sometimes have persistent symptoms, but some of them actually have none. Some of the masquerades of these arpitelitis, which I think all of us have seen in our clinics. First one is solar. If it is unilateral, consider it may be a dominant eye which has looked at it, but usually it's a bilateral and does leave a permanent deficit in a patient may have central scotoma. Again, a yellow spot like the arpitelitis that you see. What about poppers? I'm not sure whether it's common in India, but in Singapore it's very rare. This patient is picked up from the publication, but I had one patient who had come from Bangkok and had similar kind of thing. They resolved very well with stopping the drug and would have no visual deficit. What about the phenotype? Sometimes they have partly healed this kind of boggy lesion, but if you look at some of the others, they may have this kind of a changes which you see in some other pathology, which I'll show you very shortly. So in this last minute, laser-induced maculopathy is also something that you may want to look for this patient who had a similar phenotype like the one that you see in paupers. He's a 47-year-old gentleman. He had a bilateral suboptimal vision which lasted several years. So I had first seen him in 2008, and then he again presented suspected it with and had similar central scotoma. So this is not like the poppers or some other fleeting viral condition where the symptoms may resolve, but basically has genetically proven occult macular dystrophy. So just to remember that all these patients look so similar but have different pathologies. Like this patient is a dual pathology, and this is something I would want the panel also to comment on. She started off with showing signs of RPE epithelitis, and this is in 2012. And she then defaulted follow up and then came again in 2018. And I've seen her recently as well. And look at her pictures. And I just want you to um, critique some of the signs here. This is the 2018. She's also a diabetic, so she's showing diabetic changes, but she has that interning vessel. She has that little bit of crystal changes happening, and shows picture that we see in advanced cases of PFT. But in a span of 6 years is something that I have not seen commonly. So you could sometimes have the dual pathology, and I think I'll end here in interest of time. My last case was anyway dengue, which I think all of us you know about. So thank you very much,
Thank
organizers, for
thank
giving me
you.
this.